flap stops fluttering, it is the end point of safe emulsification. It appears much before the classical signs of posterior capsule rupture. When does FMS manifest? When you inject the visco, you will see how it has gone in averted. But it becomes all the more conclusive when the fluidics are introduced into the anterior chamber. And you will find when the fluid goes in, here you see it has stopped, it has started fluttering. So with flap motility sign, there is no ambiguity. There is certainty. You are spot on, and you know what the extent of the anterior capsular tear is. Thank you very much for your kind attention.
Thanks a lot, Dr. Rohit, for showing us those amazing videos. And this has been published and it has been shared. It's one of the most popular videos everywhere. And next, I will be speaking now. When I start, I will be requesting all the audience that you will have a poll coming up from the back end on your screen, and you will have the poll pop up on the right side of your video screen. And you can please look there, watch out for the poll, and you can rate Dr. Rohit Prakash's video as either outstanding or very good or less than good. And that will help us in having the poll at the end. We will be doing it for every speaker. So please go ahead and send in your polls. I don't see the poll yet, so I'll request the backend team to please initiate the poll for Dr. Rohit's video. Thank you so much. And I will be sharing my screen now. So there's only one question for you after each speaker. Please rate the video of each speaker. Now, thank you, Dr. Amar, for giving us a chance for this amazing lineup. As you can see, all the different headgears for all the panelists, for the speakers and everybody. So I think the PC rupture team is going to do it. And for me, the topic today is optic capture. Let me try and show you a few videos of how optic capture can be done in different situations. Now here is a pediatric cataract, and here we have a PC plaque, and we can see that dense PC plaque on the posterior capsule, and we have to kind of make sure that this child gets good vision. So we do go ahead, do a primary posterior capsulotomy, and you can see here that these plaques can be very, very dense, but it's pretty easy if you use the right instrumentation, the right viscoelastics. We are using a microrhexis forceps from the side port from various sides, and we've managed to get a perfect rhexis, and the plaque goes with that. And now we have the choice of putting in a lens, and I decide to put in a 3-piece lens. If you're planning to do an optic capture, it's always good to put in a 3-piece lens if you're expecting a possibility of having a PC break extend or anything else. It's good. So here we are doing an optic capture, and it's very easy. You can see I'm doing it only with a single hand. I'm just pressing the lenses in the sulcus. I've put in the first edge of the optic and the second edge, and you can see very nicely that these two situations are there. And now see how I'm going to seal the port for my pediatric cataracts. If they are very small, I will suture them. Otherwise, I'll just do this supraincisional tunnel. I'll just take you back for a moment on how I did that. I'm making a pocket just above the main incision and hydrating that with infusion. And you'll see that I don't use the typical technique where I will go and infuse on the sides of the main port. And then once I've put the fluid, I'm doing the strip and brew Seedles test, which I have described, and it is under publication. This is to check for any leaks. And we've checked all the 3 ports, and we find that the optic capture is perfect, and the child will get good vision. Going on to a second situation, I will take you to the next video. Now, this was a patient who had been operated elsewhere and was referred because the IOL had suddenly decentered. And you can see that this patient has its suture over here. The IOL had been put in the bag, and there was vitreous presenting. We put in triamcinolone acetonide. So tricot is always very, very important when you're dealing with vitreous in the anterior capsule. Very important to get the vitreous out, otherwise your lens will never center. Now, you have to understand that this lens is totally behind the anterior capsular rim. So it has almost no support. The PC has given way. So it's going to be very dicey for me to handle this. I'm trying to recenter it first and see if it gets recentered there without my having to do anything, but it does not. So it does not become stable and keeps moving to the side. So what I'm going to do now is I'm doing an optic capture. Again, this is a bimanual technique. And you can see that I've used my dialer and a white tip spatula, and I've got a beautiful capture. So this is a capture which is a anterior capture. So the IOL is behind the rhexis, and I've done an anterior capture. And this becomes very easy. Let me just take you back for a moment and show you how it was done. So what we've done essentially is that move the lens towards one side and dip it up, tilt it up from one side, and then go from the other side and use the bimanual approach to capture the optic in front. And you can see a beautiful capture there. Going on to my next video, this is another situation. A friend in Delhi had operated upon his aunt, and patient was doing extremely well. She's a very fussy lady, I remember. There is a CTR in the bag. There was no PCR initially, as my friend told me, but patient suddenly comes with double vision and she doesn't want to be touched. But I tell him that I'll try to do something, and this surgery took me barely 2 minutes. I'm using the special MST holding IOL holding forceps, which are extremely good. They go in from the side port. I move the lens in place. Now this is a single piece lens. Just watch. This is a single piece lens. There is a CTR in place. Now single piece lenses are very difficult to capture because the haptic optic junction can bend. So you have to be very careful. So I'm positioning this again an anterior capture of the lens, and just see that how I'm checking and trying to get a tuck on the lens and position it so that on both sides my capture is sufficient. You can see here now this line, and you can see this line here. So this is a single piece lens which I've captured. And going on to my last video, where this is a situation where I use a special technique described by Dr. Amar Agarwal. And this is a fantastic, this patient is post-vitrectomy and had a PC rent which was pre-existing. We had seen that on the preoperative video. I removed the cataract, and everything is going well till this situation. Now I see the PC rent, the big break is visible to me. It was pre-existing. You can see the fibrotic edges of the posterior capsular break. And I'm now worried that these small chunks will fall behind. So what I do is I go ahead and put in a three-piece lens, and I'm going to use the IOL scaffold. So I put in a lens and the three pieces of nucleus are above it. And this is a very, very useful technique, and I use it often whenever I'm in this kind of a situation. Now I can easily emulsify the nucleus. There's no risk of it going down. I go behind the lens, remove all the cortex. And once all that cortex is out, I'm going to do a capture, and that will take me home. You can see the fibrotic edges of the PC break, which was pre-existing. I'm using the bimanual itself to do my capture, so you can actually do it very nicely. That brings me to the end of my 4 cases, which I wanted to show. And this is the PC rupture team. So please remember, our next speaker now is going to be Dr. Ashwin Agarwal, and he's going to show you some fantastic videos. I'm going to stop sharing my screen. Please go ahead and take the poll. And I'll request the backend team to please ensure that the poll is happening. I did not see the questions pop up for Dr. Rohit Om Prakash. So I hope that you can please show the poll for Dr. Rohit first, and then for myself, and then while Dr. Ashwin speaks. So I'll request backend to please ensure that the poll is working. First, please have it for Dr. Rohit Om Prakash, then have it for me, while Dr. Ashwin, please start.
Okay, hi. Hi, everybody. I'm going to be talking about IOL scaffold, and just in interest of time, I'm going to speak a little fast. But scaffold, the word, it came from construction workers. It basically came from construction workers when they wanted support to actually construct something. What does it mean in ophthalmology? Well, basically, this is the biggest fear one of us always has, right? I mean, dropping nucleus pieces inside the vitreous. As anterior segment surgeons, we don't want that. So let me just explain a concept first before we actually go ahead.
We describe a new...
What we're basically doing is any nucleus piece falling inside, to prevent it from falling inside, we're using a modified PAL technique. We can bring this piece into the anterior chamber, place an intraocular lens in the anterior chamber or above the iris itself, emulsify that nucleus piece, and then place the lens in any which format you want. Secondary IOL can be done in any format. These are the reasons why we do IOL scaffold, and I'll take you through some of them. So basically, step 1, what do? We first remove all anterior cortex that may be remnant, because I want to maintain that sulcus at the end. So I'm trying to maintain my sulcus. At the same time, now, once I find my piece from the posterior segment, we can bring that piece into the anterior chamber, leave it on top. If you want to reduce the pupil size, you can do that as well. Once this is done, you can place the intraocular lens in the sulcus, making sure that the piece does not go anywhere else. And once this is done, now you have a complete posterior capsule or a scaffold or a support system that is created so that these pieces now do not fall down. The idea here is to prevent any nuclear pieces from falling down and prevent also the vitreous from coming into the anterior chamber. That's another big aspect here. Showing you a worst case scenario, this is a subluxated IOL, subluxated lens, which is fully falling in because of the trauma. Now, in these cases, usually I used to do a full-on opening of this SICS wound, and I actually used to explant this. But in this case, it was a very young patient. I didn't want to open up a whole scleral tunnel over here. So after pushing this, with using a modified PAL technique, now I'm putting some pilocarpine to reduce the pupil size, doing an anterior vitrectomy through the ports and through the main incision, placing my glued IOL under the nucleus itself and the bag itself. since it's clear, the crystalline lens is clear, I'm able to see the haptic tips, which is what I need to see. Once they are externalized from both the sides using the glue dial technique, now I can go and emulsify this complete cataract all the way, and I'll show you some of the post-operative pictures. I think that's more important, day one. This also can be used, this trick can also be used for IOL exchanges, because there's a fear of you, when you're trying to cut that intraocular lens, you can always cut the bag as well, or poke the bag, and that prevents placing an intraocular lens behind the IOL before you cut can always prevent you from a posterior capsular rupture that is eminent and very, very possible if you don't do this. So it's helped me in a lot of situations. I wanted to tell you some of the benefits of doing this is you don't need to open a corneal wound. You don't need to open a scleral wound. You prevent any vitreous prolapse. You also prevent any fragment drop. And most importantly, you also place the intraocular lens where you intended it to be post-operatively. And these are some of my videos. So thank you very much. I'm going to stop my share as of now. Thank you.
Thanks a lot, Ashwin. And now that was a fantastic presentation, Ashwin. And that's what the PC Rupture team is made of. And I'll now request our best of the best speaker, Professor Jagatram sir from PGI, to please uplink his presentation. And he will be showing us some fantastic stuff, which is award winning. So for the audience, please watch out for one of the best videos of the day.
Good evening, everybody. I thank IIRS, AIOS Professor Amar Agarwal and Dr. Gaurav Luthra for conceptualizing this unique international OPL in between these testing time of COVID-19 pandemic. I will be showing a unique case of double crystalline lens and its management.
Here is a child brought by parents at the age of 4 months, noticing an abnormal large right eye since birth. Subsequent examination of the child revealed an oblique right eye with 2 corneas joined together and a normal left eye. Under anesthesia with dilated pupils, presence of double crystalline lens was noted, separated by a small central clear aphakic zone suggesting incomplete duplication of anterior segment. Both eyes showed normal fundus with a good foveal reflex. Neuroimaging, including CT scan and MRI, also showed presence of double crystalline lens. Now what next? Plan for IOL implantation was conceptualized right from designing a special suitable IOL which could be placed into the capsular bag of both crystalline lenses. After multiple brainstorming sessions, we conjured an IOL design with maximum overall diameter of 18 mm. The central optical zone is 6 mm with surrounding 2 mm extensions. The initial steps resembled those of any pediatric cataract surgery. We performed 2 anterior continuous curvilinear capsular X's, 1 by 1, started with cystitome and completed with Utrata's forceps in both the crystalline lenses separately. Multi-quadrant hydrodissection was followed by standard steps of phacoaspiration. Specially designed acrylic foldable IOL was loaded in the cartridge, followed by injection of viscoelastic material and the IOL implanted in a way so that the leading haptic goes into one capsular bag and the trailing haptic into the other. Both haptics are now secure and the optic lies in the central part. Presence of zonules connecting the 2 capsular bags is clearly demonstrated. Incision closure was ensured. Removal of viscoelastic material and standard steps of closure followed. 6 months post-operatively, the intraocular pressure was 10 mm of mercury and the spherical equivalent obtained by retinoscopy was 5 diopters. Examination under anesthesia reveals clear visual axis, round pupil and a well-centered IOL. The central clear visual axis at the time of surgery measured 1.5 mm. As anticipated, there was progressive widening due to contraction of the capsular bags, increasing the dimension of this clear area to 3 millimeters at 6 months. The clarity of the visual axis further increased to over 4 millimeters at 1 year. The amblyopia therapy was already instituted for this child in the post-operative visits. This child is able to walk, play, and catch objects with occlusion of the normal eye. This child achieved a gratifying visual outcome after implantation of a specially designed, customized intraocular lens followed by appropriate amblyopia therapy. Thank you.
Thanks a lot,
Thank you.
Dr. Jagatram sir. And so that was the PC Rupture team, and the poll is on for the audience. You can please keep voting for us. Our team has 4 members, and I think Namrata wants to say something.
Thank you, Gaurav. As we finish the first round of our videos, we have with us Professor Mahipal Sachdev from Center for Sight, and he's the president of the All India Ophthalmological Society and has been steering a society of more than 21,000 ophthalmologists through this COVID period. So I would ask him to say a few words. So mute, sir, you have to mute.
Mahipal sir, please unmute.
Sir, unmute, sir.
Yeah. Thank you very much, Namrata. Thanks, Amar, Gaurav, and all the speakers. So whether it is an odd time, early morning, or late night for you, Ron, or evening for us, I think this is something that we all need to do. And Amar, I've been associated with him right from the beginning for this particular OPL session, and I think it brings the best out of everybody. And I think this is going to have a record viewership. Actually, COVID has brought us all so close together, and all of us are fighting a common unknown enemy that never existed before. And we all wish, hope, and pray that all of us stay safe, stay happy, stay healthy. And I think we would love to have the day again where the Indian Namaste again goes into a hug beer, and we can all hug each other without maintaining the social distance that everybody is talking about. So great show, nice to see everybody. I don't know those who watched the televisions in India. Professor Jagatram is one of the he's the director of PGI Chandigarh, and they have been doing great work as the front line fighting for COVID, and his role and PGI's role has been acclaimed throughout the world for taking care of COVID victims, and a police sub-inspector who was injured during stopping people from moving around. So I think let's enjoy this show without much ado, and we couldn't have had a better faculty than what Amar and Gaurav have put together. And welcome to this, and thanks very much for joining AIOS in this particular webinar of OPL.
Thank you very much, Mahipal. Well, we have the panelists with us, which are a lot of them there. I'll ask Ron one question. Ron, can you tell us, because see, Gaurav talked very well on optic capture. One of the things we should understand is a one-piece foldable IOL. You know, he's showing a reverse optic capture, which is a great technique. Can you talk a bit on that, Ron?
Well, I think the presentations were all absolutely wonderful. For example, Jagat's double lens, I've seen it before, but it's like I've seen it for the first time, wonderful. And I also liked Rohit's presentation, useful sign before major disaster happens. But you know what Gaurav taught us with this pupil capture, I think you made the point so beautifully, Gaurav, that actually when you're capturing these IOLs, you can capture them behind through the posterior capsule defect. You can capture them through the anterior DCC, and you just have to have your wits about you, as you showed us, that you can capture it anywhere. Great presentation.
Thank you very much, Ron. So delegates or the audience, I just want to tell you all, very nice thing which he has shown is if you have a 3-piece IOL, you can put it as the haptics on the front, that is above the rexis. But if it is a single piece, as he showed beautifully, you can keep the haptics behind the rexis and reverse optic capture it. So that means a toric IOL, for example, you don't need to explant it if you have a good rexis. I'll ask Namrata and Gaurav, can you check on the questions which I've been asking? They're pouring in from the delegates. So let's ask Namrata to tell us.
So I would like to ask Dr. Kevin Miller. Dr. Chintan Dholakia wants to know what should I do when the flap stops fluttering? Dr. Rohit Om Prakash showed very well that flap motility sign is a good sign. But when the flap stops fluttering, what should I do? And can I stain a fluttering flap with the trypan blue dye? Dr. Kevin Miller?
Well, I
Benny
think
Jeng, anyone?
you always have to assess what's left over. If you have, you know, if you're if the flap stops flapping, that usually means you've gone around the equator, and you might still be able to put a lens in the bag, but I would be a little bit hesitant. I've actually put lenses successfully in the bag with the bag actually split completely in two, so it's two halves. And I've gotten away with that, but you know, the further it goes across, the more you get anxious about that. And again, when in doubt, put it in the sulcus. And if it goes from one side all the way around to the other side, and you have vitreous coming through, you do have to worry about, even in the sulcus, it might rotate its way into the vitreous cavity. So, you know, just be careful. And you know, if you have to secure the lens to something, secure it to the iris or secure it to the sclera.
And what about Benny Jeng? Benny, we are showing this IOL scaffold, and I'll ask Benny Jeng and William Fishkind to comment on the scaffold technique, because when you have a PC rupture, you know, the problem is a nucleus present there. Can you tell us some things for the delegates to understand it better?
Sure, I'll start. The thing that really impressed me about these 4 presentations was each one built on the one before. And by the time you got to the last presentation, you could handle pretty much any kind of IOL scaffolding, any kind of placing an IOL in to protect fragments from falling into the vitreous. You have a whole spectrum of management opportunities. The next thing to recognize is not all of those opportunities are good opportunities. And so that when we find ourselves stuck in positions where scaffolding isn't going to work, then we need to make the next step to glued IOLs, or Yamani techniques. You know, that's the next part of this spectrum.
Thank you very much, Bill. And what about Benny?
Yeah, I want to just to echo what Bill just said. I think it was fantastic how it built upon each other, and I think it's a very useful technique to have. I think that if you're not comfortable working in the back of the eye as an anterior segment surgeon to float up a nuclear piece, then you should avoid doing that. But certainly if you see a lens descending and you can rescue it before it falls back and then place an IOL in there, you can phaco in the anterior chamber. I think it's very, very useful.
And we have with us Lalit Verma also, you know, who is a top retinal surgeon. So Lalit, can you tell some anterior segment surgeons some small tips on vitrectomy? Lalit?
You see, my only grudge is that Ashwin and Amar, you see, this the work for vitreous surgeon is going to go away. Because you see, you have so many techniques: glued IOL, scaffold, and then Gaurav's technique. And you see, the work for we are so much dependent on work from anterior segment colleagues. Full videos have been shown by all the 4 speakers.
So
thank you very much. Number of questions.
Somebody wants to know, and I want to ask Dr. Mahipal Sachdev this question. Does ultrasonic vibration from phaco needle not damage the IOL if accidentally it touches the IOL in the scaffolding technique, because you're continuing to do phaco over?
So obviously this is in a desperate situation that you are doing it, but then once you have put the once you have put the IOL, there should be enough viscoelastic, and normally this can only be done if you have a softish kind of a cataract. If you have a very, very hard cataract, then obviously the chances of damaging both the corneal endothelium as also the IOL, if you are too posterior or too anterior, can be there. So the normal precautions have to be taken, and obviously you aren't wanting to burn the IOL with the phaco needle. If you do that, obviously it's going to hurt that. But typically, I think in a desperate situation, it is one of the very good techniques. I have done it myself, and it saves often, as Lalit said, calling my VR friends to get me out of a nucleus that has fallen down or a part of the cortical fragments that have fallen down. But obviously, you have to assess the type of cataract that is there. What this IOL scaffold does is that it again compartmentalizes the front and the back of the IOL. So that is most important. Otherwise, you will keep on making the vitreous more fluid, and as it swells up, more of it keeps coming out. So I think it's an excellent technique, and you have to follow all the precautions that anybody would to not damage the IOL or the endothelium or the iris for that matter also.
Thank you very much, Mahipal. Well, before we move on to the second team, last person I'd like to speak. So Eric, get your team ready. But before I ask Eric to come in, I'll ask Partha Biswas. Partha, you're a top refractive surgeon. And we have these refractive surprises where we're exchanging the lens, perhaps for some mistake or the other. So the scaffold, you know, which Ashwin showed for cutting it, can you tell the delegates some tricks on that? Partha?
Partha, unmute. Unmute, Partha.
Can you please unmute, Dr. Partha?
Cutting to scaffold.
For the IOL. The question was basically for you having a refractive surprise, you know, instead of just cutting off the IOL, you know, to put the IOL behind as Ashwin showed. Some tricks for that.
So if there is a refractive surprise and if we have to repair this refractive surprise, there can be quite a few conditions in which we can do it. If it is a small refractive surprise, then it can be tackled after the anterior chamber settles with a PRK. If it is larger than that, maybe even a LASIK can be done for to correct the refractive surprise. But of course, if it is a very large one in the range of 3, 4, 5, and 6 maybe, then of course the lens best needs to be exchanged. New lens to be put in.
Thank you very much, Partha. Well, ladies and gentlemen, we now move on to the second team, which is the IOL team. And the captain is none other than perhaps one of the tallest surgeons I know, but he's got the best heart in the world. And I tell you one thing, he's a dear friend. And I love him. Eric Donenfield from New York. He's got, I don't know how many centers. He's got a roaring practice. Perhaps with his corona time, his centers are shut. But he's going to bounce back like all of us are and all of you are. So Eric, game is on. All yours.
Thank you very much, Amar. It's a pleasure to be here with you today. It's just so wonderful that the world can come together at a time like this, thanks to the technology and thanks to your leadership. Whenever I watch these video seminars that you run, I always feel honored, privileged, but mostly I feel humbled by the quality of the videos that my colleagues present. It's such a great educational experience, and to bring everyone together like this is amazing. So I'm in New York, and we're here at the epicenter of the COVID-19 virus, but we're coming out of it now, and we're feeling much better about ourselves. And I'm really excited about our team we have today. So you saw 4 great lectures about problems with lenses, and that's half the job, is getting the lens out. The most important part is actually putting the IOL in to rehabilitate the patient. We have 4 talks today about ways to put IOLs in, and I couldn't have a better team than when we have here today. An international team. We have Brian Kim talking about the Yamani technique. We have Dr. Mohan Rajan talking about IOL nightmares, and I can't wait to see that because I love a good nightmare. And then finally, we have Dean Iwano, who's talking about suturing IOL. So we have a great team. We're looking forward to all of our colleagues today having a great educational experience, and I'm ready to get started. Amar, anything else you want to talk about before we get going?
Go ahead. Go ahead, Eric. You can share your screen.
I'm going to start sharing my screen. Okay. Are we playing now?
Yep.
Good. All right. Well, I'm going to be speaking about the glued IOL, and I don't want to sound like I'm pandering to Amar here, but I would go out on a limb and say that this might be the most important technique on IOL technology since the development of the posterior chamber lens. This has revolutionized the implantation of a posterior chamber lens and has really made IOL implantation in the most difficult cases within the realm of almost any surgeon. We start by making a conjunctival peritomy. We then do a limbus-based scleral flap. We move through the sclera. I like to enter the eye about 2.5 millimeters back. And here you see the scleral flap has been made very nicely. At this time, we go and create the flap on the other side as well. And then I take an MVR blade just to make a infusion port for later on. And then I make my two 2.4 millimeter incisions. It's very important to realize this is a small incision surgery. I apply viscoelastic. I usually place a dispersive viscoelastic. And then I take the MVR blade and I enter the eye going straight backwards so I can see the tip of the MVR blade. I place my trocar. I like this one, but the one I like best is the one that Amar developed, which is a sleeve trocar. Inserts very nicely. And then hook up my infusion. Now I do my pars plana vitrectomy. It's very important to move vitreous. This is done with a gentle aspiration to move vitreous from the front of the eye in a very controlled environment, well within the realm of almost any good anterior segment surgeon. And then following the removal of the vitreous, we place the IOL. Now, my IOL of choice that I really like here is the CT Lucia from Zeiss, but it's not always available, especially in the United States. Sometimes we can't get it. So there's any three-piece lens works well. I also like the Bausch & Lomb Soft Quad AO. And what I like about the glued IOL technique, Amar, is that there's less manipulation of the lens. I find that especially if you don't have the CT Lucia, there's less risk of kinking the haptic or breaking a haptic, which can happen with the added manipulation of the Yamani technique, which I also like. I think that it's a very nice technique as well. What I also like about this technique is that the haptic tends to lay flatter afterward. There tends to be less lens tilt in my hand with this technique, and the IOL centers very well. The haptics are now externalized, and you can use a 15-gauge needle. I like to use an MVR blade. I create a little tract, and then I just basically insert the haptic into the tract that I've made so that the IOL haptic is sequestered beneath the sclera. I cover the flap up, and then very simply apply glue, tissue glue here, and it's called the glue IOL, but the glue is probably the least important part of the procedure. And then once the glue is applied under the flap, I smooth down the conjunctiva, and this basically completes the entire procedure. The procedure can be done in just 15 minutes or so. The IOL is stable. They tend to last pretty much forever. We've been doing this now for, it seems like, 10 years, and I could not have been more delighted with the results of this technique. So with that, I'm going to stop my video, and I will stop sharing. Oh. And I'll take it back to my team. So that's the glued IOL technique. Amar, my hat is off to you for this technique that you have revolutionized. You have changed all of ophthalmology. And when I said at the beginning, I really stand by, this is the most important development in IOL implantation since the development of the posterior chamber lens. So everyone, my team members, hats off to Amar Agarwal for the glued IOL technique.
Thank you very much.
And now I'm going to turn over the microphone to my colleagues. We have a wonderful group here that will be presenting on IOL techniques here today, and we'll go to the next technique for scleral fixation of a lens with Brian Kim talking about the Yamani. Brian, please take over.
And please remember, the voting is on, so you can start voting for Dr. Eric on your platforms, and please go ahead and poll. It'll remain on for 2 minutes, and then the next poll will come on. Thanks.
Okay.
All right, can everyone hear me?
Yes, Brian.
Okay, great. Well, I want to thank Dr. Agarwal, Luthra, and Sharma for having me on this very interesting but also exciting way to be able to communicate across the entire globe and to be connected in a time like this. So I pray blessing and safety and well wishes to everyone. So I'm going to discuss 3 essential pearls, in my opinion, to successfully execute the Yamani technique. And so pearl number 1, some of the criticism of the Yamani technique is just the unpredictability of the lens placement. And so The problem is the marking of the conjunctiva is insufficient because the conjunctiva can cause inaccurate needle placement because it can move. And so marking the conjunctiva is important, but the conjunctiva must be fixed in a position for proper scleral needle placement. And so you can see on the left side here, the forceps is holding the incision, and on the right side, the trocar is being held. And so I'm going to illustrate this with a video. So the trocar is held with the forceps to stabilize. I want you to appreciate how neutral the conjunctiva is in this position. And so by maintaining the conjunctiva in the neutral position, you can more predictably place the scleral placement of the needles. Rule number 2 is to dock the haptic on the needle. So the problem is the haptic is curved and the needle is straight. And so that's why people struggle to thread the haptic into the needle. And this is not really vocalized by a lot of the experts, but in my mind, this is why some people struggle when they learn the technique. And so the solution is to dock the haptic on the bevel of the needle. And so you don't want to advance it quite yet. You want to straighten the haptic against the bevel, and then it should slide easily into the needle. And so note, the haptic must also face the bevel of the needle to facilitate the docking. And so in this case, the left side needle, the bevel is facing away from you, and the right side bevel is facing toward you, but the bevel is always facing the haptic. And so this is illustrated here. It's difficult to thread when the bevel is not in the correct position. That's because the needle is straight and the haptic is curved. Dock the haptic on the bevel of the needle, flatten it out, and then advance the haptic. And pearl number 3 is trailing haptic first, which I published back in 2018. The original technique, the leading haptic is inserted into the left side needle, and the trailing haptic is difficult to fixate. And so all of my students that they struggle with this step when I've taught this in the wet labs, but this modification, whenever I taught it to them, they've been able to cannulate the trailing haptic very easily. And so the principle is simply, when the forceps are used to pull the trailing haptic to the left in order to fixate, the left side and haptic needle complex resists the straightening of the trailing haptic. And so you can see how this is illustrated here. It's difficult to cannulate the trailing haptic because the leading haptic needle complex resists manipulation of the trailing haptic. And so the solution is to externalize the leading haptic through a contralateral limbal incision to improve access to the trailing haptic for needle fixation. And so Pearl 3B is to place the trailing haptic within the incision in a U-shaped configuration. And the apex of the U happens to be the perfect place to grasp the haptic to thread the needle, or to thread the needle, correct. So this is a modification. Your technician advances the IOL, and the surgeon externalizes the leading haptic with microforceps, the trailing haptic swept to the right, and then the trailing haptic is captured within the incision in a U-shaped configuration. The apex of the U is the ideal place to grasp the haptic. Note the bevel of the needle is used to dock the haptic, straighten, and then advance. The leading haptic is internalized with microforceps and placed into the angle. And the leading haptic is docked on the bevel of the needle, straightened, and then advanced. So in summary, pearl number 1, firm globe fixation enables a more precise needle placement. Number 2, docking the haptic on the bevel of the needle is an easier and more reliable way to thread the haptic into the needle. And number 3, trailing haptic first modifications offers an easier way to thread the trailing haptic into the needle. Thank you for your attention.
Can I go? Sir, sorry, go, sir.
Well, Brian, I thought that was exquisite, really good technique. And now we're going to move on to our next speaker. You're voting now, I hope. I would be voting Brian as one of the best videos I've seen all year. But we have some IOL nightmares, and you never know what's going to happen in a nightmare. So for those of you who are in Asia, where you're maybe thinking about going to sleep soon, I ask you to be safe after you watch this video, because these nightmares can be very difficult to sleep with afterwards. But we're going to have Dr. Mohan Rajan talk about IOL nightmares.
Thank you very much, Eric, and let me thank Amar, AIOS, IIRSI for this wonderful webinar. This is the 66th webinar the OPL I've been attending. And IOL nightmares are very, very common. If you keep recording all the cases, then you probably understand what exactly is this IOL nightmares. So look at this MI6. Basically, it was introduced in 2005. It didn't have a good cartridge, and only half the lens came into the eye. That's called the MI30 lens. Okay, and this is the very new lens, which is this is another patient with a preloaded lens. You have to be very careful about this preloaded lenses. Okay, this preloaded lens, you do not know what's happening inside the lenses as well. You can see that there's a large hole right in the center of the lens, in this optic, in this lens. One of my residents was asking me what type of this lens. I told him this is a very new type of lens called the pinhole lens, wherein through the pinhole the patient will be able to see better. Then there's another patient can see again a preloaded lens, a Zeiss Lucia lens, and the first time in the world they say is a heparin surface modified optic. You can see that optic is coming first, and then what happened to the haptic? The haptics are coming later, and this is again a preloaded lens, because the preloaded lenses you do not know what's happening inside, as I told you earlier. This is a patient who had wanted a trifocal lens. You can see here the trifocal lens, and you can see that there are three parts of the lens: zone 1, zone 2, zone 3 in the trifocal lens. Okay, the zone 1 is for the distance, zone 2 is for the intermediate, the zone 3 parts of the lens, the trifocal for here as well. This is, as you know, this Envista lenses doesn't unfold. Okay, suppose you put the Envista lens today, it will unfold tomorrow, but this lens never unfolded at all. You can see this acrobatics in the anterior chamber. I am waiting for 3 minutes, 5 minutes, 8 minutes. Then obviously we have to explant this lens, and this lens Envista never unfolded in the eye. This again, you have to be very careful of the shooters. The shooters, which is very, very careful. A shooter can rupture the PC, and the IOL can drop into the vitreous. You can see the IOL dance into the vitreous as well. One of my optometrists came and told me, sir, there's a patient with a recurrent mature cataract, and there's nothing but an opacified IOL. You can see this opacified IOL, hydrophilic lenses, which we reported way back in 2002 in the AIOS as well. Again, this is the Envista lenses. The Envista lenses came into the market. They didn't have a proper injector, and the haptic never used to get caught in the injector. You can see if you try to pull it out, the haptic will get cut. That's what you should not do. You can see here, this is another patient with a supraphobe in-focus lens, which is made by a company in India. You can see that the haptic is getting caught in the cartridge. You can see that the cartridge thing. Don't try to pull that haptic out. So what is important is to take a 11 blade. Okay, take a 11 blade and do what is called an episotomy. I call this ocular episotomy. Open up the cartridge very nicely, and then you can release the haptic very beautifully without any problem, without any deformation of the haptic or anything like that. So this way you can save the lens and save the explantation lens. Another patient, you can see here preloaded lenses. Again, you can see here that the silicon plunger also comes along with the lenses. This is called the blue whale. Again, this is a haptic which is getting caught. It's very common in acrysoft lenses and Technics lenses. Again, haptic which is getting caught on the back surface of the lens as well. This is a very, very rare thing which has occurred. This patient wanted bilateral simultaneous cataract surgery, and I put both the lenses in the same eye. What is this, both the lenses in the same eye? You can see the first lens, and then you can see the second lens also coming. This is again a preloaded lens. You can see here, first lens, and then the second lens also coming into the eye. This is the IOL nightmare of this thing. So what happened? I took the second lens and put it in the fellow eye as well. You can see this is a patient referred to me and for IOL explantation. This is IOL number 1, the anterior chamber lens. Then IOL number 2, which is an aqueous Boschenbaum lens. Then IOL number 3, which is the rigid lens. Okay, and rigid PMMA lens. So all 3 lenses from the same eye. Apart from that, the patient also had a CTR and a nucleus piece. Now all this ophthalmologists are done for $150. take-home message: load the IOL yourself, use the time-tested injector systems, check the compatibility between the IOL and the injector, beware of preloaded IOLs, do not be complacent, which is normally when you're at the end of the surgery. And that is the IOL nightmares which I wanted to present. Thank you very much for the wonderful opportunity.
Oh.
I'll stop share now. Yeah.
Well, that was extraordinary. So thank you for sharing your nightmare with us, and maybe we can all avoid some of them thanks to your wonderful
So it's
video.
a great honor to be in your team, sir. Because I have seen your AIO OPLs and you're really fantastic.
You're very kind, very, very kind. And now we're going to have our final talk. In the United States, we call this batting cleanup. And this is the person who's going to bring us home on our session. We have Dean Iwano, who's going to talk about suturing IOL. Dean, I do less suturing IOLs now, but occasionally I still use this technique, so I'm looking forward to your pearls from your video.
Thank you, Eric. I'm going to share my screen here. This is my current technique for scleral suture fixation of a PC IOL. I prefer this technique because there's no IOL tilt, decentration, haptic extrusion, and this is basically the polar opposite of a Yamani technique or a glued IOL technique, because all the complex steps are done outside the eye. These are the items you need. I'm sorry about the quick pacing of the video, but you can email me for the details. And this is a quick overview of the technique. A calibrated diamond knife is used to make a 250 micron deep incision in peripheral cornea. This is going to be 3.5 millimeters wide. It's important that this is 180 degrees apart. The construction of the extended length Hoffman scleral tunnel is important. I use a tooth forceps to lift the roof of the tunnel. You're going to expose the gray floor of the tunnel and dissect and advance about 5 millimeters posterior to the limbus with a Yamani mini crescent knife. If you see a subconjunctival hemorrhage or visualize the blade, your tunnel is too shallow. So to keep the dangling lens complex from falling posterior, I like to use a zip line, which is a Gore-Tex suture threaded through a 27 gauge needle. And you can use this zip line as a safety harness to keep the lens from falling to the retina. So you do a vitrectomy to clean up any vitreous traction. You'll need a 7.5 millimeter incision to implant the new lens. Notice as this lens is coming out, you'll see a pro-inflammatory some rings ring. And this is one of the reasons why I stopped using lasso suture fixation. So to externalize the ends of Gore-Tex suture through the smallest possible incision, I use a suture snare, which is a 9/0 nylon suture threaded through the bore of a 30 to 33 gauge needle. You pass the needle snare 3 millimeters posterior to the limbus, directly over the scleral tunnel, angling towards an imaginary center of the natural lens. You retrieve the loop of nylon with a Kugelin hook and pull out the main incision. Pass one end of the Gore-Tex suture through the loop and pull the nylon suture out in the reverse direction. You repeat the same step 2.5 millimeters adjacent to the first arm of the Gore-Tex suture. And once you've created 2 loops of Gore-Tex suture, you are ready to fixate the lens. Now, this is an anti-torque, symmetric anti-tilt fixation. To make things easier, use a small segment of 9/0 nylon suture as a pull guide. Always pull the loop of Gore-Tex suture from under the haptic, through the eyelid hole, and around the distal end of the haptic. Again, this is an anti-torque configuration. It's symmetric. Insert the IOL into the proper position and pull evenly on the Gore-Tex suture. You will notice that the lens stays centered before the suture is actually tied. And it makes no difference whether the suture is tied tightly or loosely. And that's because the Gore-Tex suture, which is 90 microns thick, is externalized to a 200 micron needle tract instead of the typical 1200 micron scleral puncture. And notice the stability of the Purkinje images. The suture is threaded out the tunnels and then tied with a 111 knot, and the sutures are tucked safely into the scleral tunnel. If done properly, the Gore-Tex suture is permanently integrated into the sclera without any risk of extrusion or exposure. And you'll end up with a stable, here the Gore-Tex suture is integrated into tunnels. You'll end up with a stable tilt-free IOL that is completely independent of iris or pupillary anatomy and can be done in any anterior segment size, small or large. Thank you, Amar. Thank you, Aaron.
So
thank you very much.
Thank you. I have a few questions now here. The first question is for Dr. Ronald Yu. Which technique do you think, 3 techniques were demonstrated for scleral fixation, and which is your most favorite technique?
Also, I'll remind everybody to please vote, because the voting will finish off for this previous team in a few seconds from now. So please finish off voting. Yes, Ron.
Thanks for that great question. Actually, I was looking at that and thinking myself what the situation is in Singapore. And you know what I'd like to ask Brian in turn is, I loved your presentation. You made it look so easy. And I think that many people in Asia, and certainly in Singapore, ended up not doing Yamani very much because they had problems exactly as you mentioned. And one that you didn't mention was how the Yamani, how do you don't use the guide, and Yamani's come out with the guide for the needles, and how important is that in gaining success? Because otherwise, I would say in Singapore, we are doing much more of what Eric had shown, a variant of the glued IOL where we actually stitch the thing in the side in the Sheriff's pocket. But Brian, I'd be grateful on your take.
Thank you. So I think first of all techniques are excellent. The glued technique, the Yamani, and using Gore-Tex suture to fixate to the sclera, I think they're all excellent and they have their place. With regard to the Yamani, Dr. Yamani's device is excellent, but I don't believe you can adjust the corneal size with that ring that he developed. And so I worry about the distance from the limbus posterior. I go about 2.5 millimeters back. And so with that device, there's no way to adjust for that. And so that's my main concern. I think in principle, you're able to angle the needle 20 degrees, which is the ideal place. And that's kind of why I was alluding to the fact that you have to keep the conjunctiva in a neutral position. Because if you don't, and the conjunctiva gets distorted and you're following the marks, well, then it's going to be tilted or decentered. And so I think that is a big limitation of the technique. And so obviously, Dr. Yamani developed that instrument because of that. But yeah, I think that is a challenge and an issue.
And the next, thank you. And next question is for Benny Jeng. Benny, we have a lot of situations wherein the cornea is a little bit hazy and you need to do a glued IOL. So which technique would you use, or rather do a scleral fixation IOL? So which technique do you think will stand the test of the time, and which one would you do in cases where the corneas are not very clear?
So I think it's very situational for me. I explant a lot of ACIOLs. And if I'm going to make a larger wound to explant that ACIOL, I actually will suture in a one-piece lens, as Dean has shown very elegantly. It can be done without much visualization, and it has to be done through the big wound. Now, if I'm primarily putting in a secondary IOL, I like the smaller wounds, and so I'll preferentially do either a glued or a Yamani. And I find that the view is actually reasonable for both techniques, and so I'll vary depending on the patient. But if I don't have to make a big wound, then I'll definitely do the Yamani or the glued. I've been doing more the glued lately.
So there is another question for Dr. Eric. What kind of forceps do you use for the glued IOL, and what kind of IOL do you use for the glued IOL? These were 2 questions put up by Devdutt.
Yeah, so for the glued IOL, I like the CT Lucia, the Zeiss lens with the most flexible haptics of any haptics we have. So that's my IOL of choice. As I mentioned, sometimes it's not available readily. In that case, I will use a backup of the Bausch & Lomb Softport AO, but Alcon and Johnson & Johnson both make very nice lenses that you can use here as well. As far as the forceps are concerned, any micro forceps works really well, and I've designed one, but there's so many good ones that are out there. I don't want to mention one brand name specifically because they all work very effectively. The whole key is to make sure that the haptics close effectively. So I always like to look at the haptics before I insert into the eye to make sure they close, because there's nothing more frustrating than putting the micro forceps into the eye, have it close, and have it not hold on to the haptic of the IOL. But they all work very nicely. What do you like to use?
Dr. Amar has designed one forceps, and that works beautifully for me. Dr. Amar, would you like to talk about that?
We use the glued-IOL forceps, which are made by MST or Epsilon. Both are, and many dime a dozen companies now are making these. The idea is very simple, that they have now 25 gauge. So they pass through very nicely and comfortably. The only problem which I was seeing in the Yamani, which we tried, was the tilt of the lens. Whereas in the glued IOL, we don't get a tilt. One small trick which I tell everyone is, if you have a large eye, make a small iridectomy in the area of the scleral flap so that you can come even 0.5 millimeter to 1 millimeter from the limbus, so that when you enter the sclerotomy, you will not create any damage to the iris. Saying that, I think one more question I'd like to ask, if anyone in the panel, what about the Canabrava technique, which is another very nice thing which started by Sergio? Anyone tried it out?
I tried it out.
Yes, Mohan, a few comments on that also, please.
Yeah, I think it's a very good technique, especially because you can use the cautery and you can, it's something similar to the Yamani technique.
Yeah.
Technique.
It is using the suture in it. Thank you very much, Mohan. Can I ask Bill Fishkind to say some comments, and then we'll move on to the next team, which is Mitch Weiker's team. So Mitch, get ready, but I'd like some final comments for this from Bill Fishkind.
Well, again, this was a very broad discussion of different methods of fixating lenses when capsular support is questionable or non-existent. And as we deal with more and more complicated cataract surgeries and ended up with some unexpected postoperative results weeks, months, or years later, we certainly need to school ourselves in the ability to do these fixation choices and to tailor each of these options to the specific anatomical issues that are associated with the patient we're operating on. So the bottom line is we need to know how to do these, and we need to practice doing these, and we need to feel comfortable doing these. So in a pinch, when a problem occurs, we can deal with it and give our patients the outcomes they expect.
Thank you very much, Bill. Well, ladies and gentlemen, let's move on to the third team, which is the cornea and the iris team. And that's captained by none other than perhaps one of the persons who's won in American Academy OPL. I don't know how many times he's won it there. And that is Mitch Weiker. Mitch?
Thanks, Mar. It's always great to be here. Thanks as well to Namrata.
You have a great headgear on, Mitch.
Well, it's always good to get together with friends, even virtually in these times when we're fighting this alien invader. So I just want to tell a comment
before you continue, Mitch. And I want to tell all the audience this. You know, in the American Academy, in the OPL, one day, just day before, David Chang pulled me and said, let's go to Mitch's room. So I went to Mitch's room, and he had a huge green screen in his room. And he and David Chang, when they were preparing, you know, the introduction for the American Academy OPL, you know, it was out of the world. So Mitch, go on.
Thanks, Mar. So we are the Corona Crushers. We've been on house arrest for 8 to 10. That's weeks so far. We've got a nice assortment of heavy hitters here. We have Dr. Namrata Sharma, myself, Dr. Susan Jacobs, and Dr. Suhas Hadapakar. So we're going to start this off with Namrata, and she's going to talk about simple limbal epithelial transplantation.
Okay, so I think our team is the most important, because if the cornea is not clear, neither can PC rupture team, nor IOL team, nor devices team can function. So we start with this presentation, and it is called, Hey, there is an eye there. So, hey, there is an eye there, so you need to dig it out. You need to dig it out for the patient, and you need to dig it out for yourself to see that there is actually an eye there. You get cases of corneal transplants like this, and they invariably fail because of the limbal stem cell deficiency in these cases. And so what you need to do is take the limbal take a small limbal piece and do a limbal stem cell transplantation. And this limbus acts like a magic wand. So from the fellow eye, you have to take a small limbal tissue and place it onto the eye, which is the affected eye. Now, this is the normal fellow eye. So you dissect 0.5 millimeters into the clear cornea and 1 millimeters behind. So this is the limbal strip which is taken, and partial thickness dissection is done, which is about 40% depth, and this includes the palisades of Vogt or the limbal stem cells, and this acts like a magic wand for the fellow eye. So when you look at cases of limbal stem cell deficiency, and this is a chemical injury, you pinch the conjunctiva where it is loose and do a 360 degrees peritomy, and as you do it, it is just ready to strip off. And just notice how the underlying cornea and the underlying surface is so clear. So a glue is placed onto the corneal surface, followed by the amniotic membrane, and the limbal lenticule, which had been obtained from the fellow eye, is cut into small pieces and then is placed circumferentially all around except the central area, which is left clear, and this is again pasted with the help of the glue. This is followed by a bandage contact lens application. Now, this is a very simple procedure. It is like a lab which is in the eye itself, and look at this patient. This is being done under intraop OCT microscope, hopping from clinic to clinic. But if you don't take that eye from there, then who's going to do it for the patient who's been just prescribed lubricants without actually having to do anything? So again, when you dissect from the limbus and you remove the pannus all around, you see that there is a clear cornea there, there is iris there, there is a pupil there. So again, this is the bed on which the limbal lenticules will be harvested. It is like sowing seeds onto the ocular surface itself. You don't need a lab to cultivate the stem cells because the cells are being cultivated on the eye itself. So this is in vivo cultivation of the stem cells, and a bandage contact lens is placed again there. And notice this is 6 by 6, 20 by 20 vision with a clear ocular surface, and you didn't have to do a corneal transplant for this procedure. Again, this case, where is the eye there? So you again have to dig out the eye there and also dig out for the patient to see. So again, you remove the pannus, and sometimes when you're not that fortunate and the underlying cornea is a little bit hazy, there you can do a partial thickness transplantation. And again, notice that as you remove the overlying stromal layers, they're just waiting, they're ready to be stripped off. And again, you will see that there is an iris there and there is a pupil there, and you're still extraocular. You have not entered the eye at all. It is an extraocular procedure. So where corneas are hazy underneath, there you may do a corneal transplant combined with it. And this is the post-op picture again with the visual acuity of 20 by 30. So there is an eye there. This is after 6 months, patient referred for corneal transplant. You didn't have to do a graft. You just did a surface procedure. Yet another one referred for corneal transplant. And this is 8 years follow-up with 20 by 20 with no corneal graft, no problems of rejection. Now, this was a multicentric trial of which we were a part of, and the success rate is 83.8%. It's an inexpensive, simple procedure, and the results are very gratifying because you don't have to do a corneal graft in all the cases. 1 out of 4 may need a corneal graft where it is hazy, but otherwise the results are spectacular. Without having to change the patient's cornea, the patient can see in almost 80% of the cases. So, hey, there is an eye there. Please dig it out for the patient and for yourself. Thank you for your kind attention.
All right, thank you, Namrata. That's an amazing way to rehabilitate an ocular surface. So as soon as our share stops. All right, so I'm going to share my screen now. And I'm going to talk about fourth row pupilloplasty and pupillary sculpting. This is a technique that I learned from Amar and Ashvin, and it's a very nice way to repair the iris. Very simple, very easy, and very fast. We've seen their videos before, but we end up passing a suture through a paracentesis, down through our iris, back up through the other side of the iris defect, and then out through the cornea, which doesn't have to be through a paracentesis. We grab one side and pull a loop through out the other side in a Suture fashion. And then we're going to take and wind our one free end around 4 times. We're going to loop it around and pull it through to create our tie. And then we're going to pull that side into the eye while we hold the other side to internalize that loop and that knot. And then we're going to tighten it down by pulling the sutures on either side. And it gives us a nice, quick, easy way to repair the iris. And then we can just use some intraocular scissors and cut our sutures there. So this is a case of a patient that had had trauma, had already gone through lensectomy with a secondary IOL implanted as well as a corneal transplant, but was left with this iris defect, and they had a lot of glare. So luckily, this patient came to me after I learned this technique from Amar and Ashwin, and so it allowed me to easily repair and sculpt this pupil. So we're going to go in, and here I'm going to make, in this case, I make 2 paracenteses, but we don't necessarily need that second one. This is 10-oproline. A lot of people prefer 9-oproline because it's a little heavier. We're going to go and pick our points on the iris, which is typically about a 0.5 millimeter from the edge of the iris. If the iris stroma is a little atrophic, you can make that bite a little bit bigger. We're going to go in and retrieve our one suture loop in a Suture fashion. You can use micro forceps for this. It might be a little easier. Sometimes a hook can get caught in the paracentesis. So I like to identify the long end there and loop around the long end rather than the other end. And so here you can actually tie it around and loop around your forceps to pull it through. We see Gary Condon prefer to do that. I'll do it a different way on my next pass. But once we get that loop, then we're going to pull it inside the eye very carefully, not too fast because we don't want our things to get tangled. And then we cinch it down there. I'm going to go in through a 3rd paracentesis and then just cut my suture. And what I did there was align the edge of the sphincter. But the nice thing about this technique is you can change it as you go. You can add sutures and remove sutures. So I'm going to continue to close this defect sequentially. And this is a CIF4 needle. Instead of passing the needle through the cornea, what you could do here is dock with another needle. So you come in the other side with a 27 gauge and you dock your needle in a railroad fashion. And we're going to pull our loop through. So instead of trying to twist and wind around forceps, we're just going to take the end of this and pass it under and over and under and over 4 times. Sometimes that's a little bit easier as well. And again, I like to stay on the side of the loop that is the same as the long end of the suture that goes all the way across the side, the other side. And I pull it down, I cinch it. You only need those 4 throws. You don't need to do another pass and tie it again because those 4 throws really hold it. So I'm going to finish up and close this one more time in a similar fashion. So it took me 3 sutures to close this. I'm doing my loop one more time. And you can see how I was able to do this through a single paracentesis that was placed strategically, kind of in the middle of that expanse of the iris defect. So once I cut this, and I'm going to reassess here. Now you can see I've got a little bit of decenter pupil here, so I'm going to remove that first suture because I'm not really happy with that. So it is a reversible technique. Now I've got an ovalized pupil here, so I'm going to now sculpt it. So here's one way you could do it. I can make little sphincters here on each side. And once I do that, I think, well, let me pass one more suture to center things even a little bit better. So again, you can take your time and alter your technique to get that pupil as perfectly centered as possible. I'm going to do more sphincterotomies here. And now I'm going to remove a little bit of this iris tissue to round out my pupil. Now here I'm doing it with scissors, but you can also do it with a vitrector. That works really well. So once I remove this, and you want to do a little bit at a time because it's easy to do too much and then get too big of a pupil. And so now once I've got that pupil, I think it's pretty done. So I'm going to remove my viscoelastic and reassess. And it looks pretty good there. So I'm very satisfied with that. So we're done. And you can see here in just a second the final result. Because I passed that CIF4 needle through, I've got to suture that up. And you can see our final result there. So this is using that 4th row pupilloplasty. It's a really easy way to repair these iris defects and really sculpt that pupil. So thank you very much. So next up, we've got Susan Jacob, and she's going to talk to us about PDEC.
Thank you, Mitch. I'm just going to share my screen. All right. So as Dr. Namrata said, you know, we of the Corona Crushers, the Cornea and the IIRSI team are the ones you guys have to cite for, because we're going to show all of what has been done previously and then some more. So we are the guys to vote for. All right. So I'm going to play my video. Now, this was a young boy, about 12 years, and I'm going to show you a PDEC in this case. And the reason also that I'm doing a PDEC and not a DMEC or a DZEC. I'm sorry, is my video showing? I'm sorry, my video showing?
Yes.
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 All right. Okay. So
Went off.
all right, I think I'm back again. Okay, I'm not going to touch the screen now. Okay, so this is a child, 12-year-old, who had a failed graft and also a cataract. And this is a PDEC that's going to be done. You can see that that graft is quite edematous. I've removed the epithelium. Since he's also got a cataract, I am also removing the cataract by doing a phacoemulsification. You can see that there was some fibrous membrane over the cataract that had to be removed first, followed by a rhexis. That's the rhexis that's being done. And it's a soft cataract. So I've removed most of it, except the superior half, which I think that I'm going to remove after implanting the IOL. So I've got the lens in the bag, and I'm trying to get rid of that superior cortex. But that's when I notice what happened. I've got a postcapsular end. And so here, I'm going to be doing a reverse optic capture. You can see that I've gone below, and I have got that IOL optic captured well in the rhexis. And this is the reason this case is important to show, because it shows you a lot of different maneuvers that are required to this entire surgery successful. I've done a pupilloplasty. I've done an IVT-assisted vitrectomy to make sure there are no vitreous strands in the anterior chamber. And now this is one important step that I want all of you to see. I've got an anterior chamber maintainer in the eye, which is pumping in air. So this is the air pump assisted PDEC technique. And you can see that I could easily visualize the descemet membrane. The antechamber is held wide open without the use of any viscoelastic, which could later interfere with graft adhesion. So I've just got only air there. I'm much more certain that my graft is going to adhere. I've got the graft injected into the anterior chamber using the E-PDEC technique or the E-DMEC technique to make sure that the graft is oriented the right way. And this is why I say that PDEC is so much better than DMEC and DZEC, and this is my go-to technique. And the way to do it is with the air pump assisted technique. Now you can see that there would have been no PDEC surgeon, no DMEC surgeon who would have accepted that. I'm just going to rewind that. This would not have been done by any DMEC or any DZEC surgeon. Having a decentered graft like that with those edge folds over there, that's just simply not acceptable. But I'm going to do that, and the reason I'm going to do that is because I'm so certain that I'm going to be able to do it well with my air pump assisted technique. So I've got that graft decentered there. I've got air in the anterior chamber, and look at that, how easy it makes it for me to just pull that graft into centration, and now I've got a completely centered graft. So I didn't have to do that DMEC dance, which people enjoy so much or seem to be enjoying, where they keep tapping for so long just to get that centered graft before you float it up. My procedures actually become so simple. I've removed those edge folds. I've got a nicely centered graft. I've removed that antechamber maintainer, which was pumping in air, replaced to get an 80 to 90% airfill. And you can see the post-operative result your own, a very complex case, a patient with a failed graft, a cataract surgery, as well as a postcapsular rent with an optic capture. That was, I think, a tough situation for doing a thin membrane enfield keratoplasty, and managed very well with a PDEC, and all thanks to the air pump assisted PDEC technique, which really is a must to do and learn if you're going to be doing this technique. I'm also going to show you another very interesting technique, which I had described, which I call as a host decimetric scaffold. And this, you know, is one of the major complications of DMEC or PDEC, which is basically graft detachment. And I'm going to show you this technique just to show you how easy it is to prevent graft detachment. Now, this is one thing that none of endothelial keratoplasty surgeons like, which is having the host decimetric membrane lying above the graft. Because if that happens, what happens is that the graft tends to detach, and that's why you always make a smaller descemetorrhexis than a larger descemetorrhexis than the graft size when you're doing a DMEC. Now, my thought was, why would you want to have that or waste that host decimetric membrane? Instead of having it above the graft, where it can detach the graft, why not use it below the graft as a scaffold? So this is a scaffold technique where you're actually using the host's own Descemet's membrane to prop that graft up and hold it firmly against the host stroma and prevent it from dislocation. So just to show you an animation, you make a small Descemetorhexis, take a graft that's larger than the Descemetorhexis, float it up, have the air pump assisted technique going, and then just go and tuck that graft in under the host Descemet's membrane, using that host Descemet's membrane, the residual part of it, to your advantage and to prevent graft detachment. You can see that that air pump assisted technique really helps you in doing a lot of maneuvers, holds the antechamber well open. That was the endo-illuminator assisted technique, showing you the graft orientation. I've got the air pump back in. It's pumping in air at about 30 millimeters mercury, and you can do this with either the vitrectomy machine or with newer phacoemulsification machines like the Stellaris. And here you can see what I'm doing. I'm pulling that graft, pulling that host Descemet's membrane from above the graft to a position that's below the graft. So I'm actually teasing it up, and this can be done only with the air pump going on because you need a well-formed anterior chamber. I've got that host Descemet's membrane supporting the graft from below, and there's also a variant that you can do, which is basically wound scaffolding, where you can pull a part of the graft into the wound, not crossing more than 50% of the horizontal length. And you can see the results in all these cases, very clear corneas. Here's another example, just showing you how easy it is to do this. Make the Descemetorhexis smaller and then just put it below the graft. Here are some tough cases which people would generally do DZEC for, but I've done a combination of air pump assisted PDEC and host Descemetic membrane scaffolding and got good results. So you could do this scaffolding as bilateral scaffolding, multi-point host Descemetic scaffolding, or a combination of host Descemetic scaffolding and wound scaffolding. And this is what I want to show you. Instead of having this gap between the host and the Descemet's membrane, have the PDEC graft actually supported by the DMET graft, by the host Descemet's membrane. And just to show you that ASOST again, because that's a beautiful ASOST. This is the PDEC graft, and that's the host Descemet's membrane. And you can see how it is supported by the host Descemet's membrane. So here again, you can see you do need the air pump assisted technique to do that, because if you don't have continuous air flowing, the antechamber is going to collapse, and that's why that technique is so important. You can get a good host Descemet's membrane scaffolding and very good results. Thank you so much.
All right, thank you, Susan. So now we've learned how to rehabilitate the anterior surface of the cornea with Namrata, the posterior surface of the cornea with Susan. We talked a little bit about repairing the iris. So next up, we're going to finish with Suhas, who's going to tell us how to use pupilloplasty to improve our vision. While he's getting started, I'll remind the audience, now's the time to vote. So keep the cornea crushers in your mind as you pick your best speakers here. So Suhas?
Yeah, I'm coming. Are you seeing this?
We are not seeing it yet. And I just wanted to remind people that if they are not able to see the vote, some people have sent in that they can't vote. If you just refresh your window, it immediately comes up. I did that. Dr. Namrata also mentioned to me that the voting may not be working. I've just done refreshing it. It brings up immediately. So in case you see that the poll doesn't work, just refresh it and the vote will work. I just voted for Susan. Yeah.
Are you able to see the?
So we cannot see it. Can you go to share screen and click on the PowerPoint?
I did that.
Once you click on share screen, a window will open up. There you have to look for your PowerPoint and then click on that, double click on that.
Oh, where is it? Oh my God.
First go to stop share again. If you're doing it, stop share, start the presentation, then start share screen.
No, okay.
Just double click on the PowerPoint.
Now,
You have to go to start share.
I did start share.
And then click on your PowerPoint. Subhash.
Now
click on your PowerPoint.
He has a video. He doesn't have a.
I have a video I have a video on the desktop.
So
Suhas, first stop share first. Stop share first. Stop the sharing. Now play your video. Play your video.
One sec.
Pause it.
Let it even play, it doesn't matter. And then press share screen. First play the video.
Okay.
And now press share screen.
And then find the video and click on it, double click on it. On the share screen options, your video will be visible as one of the small windows.
Are you not able to get it? Suhas, can you ask some questions, Namrata?
Yes.
Gaurav?
Dr. Benny Jang
Yes,
is there?
we have a lot of questions. Namrata can ask first.
Benny?
Yeah, Dr. Benny is there?
Yep, here.
Yeah, Benny, so what is your take on PDAC technique, which Susan so beautifully showed?
Well, I've talked to Amar and Susan about this.
Versus DSEC, all three together.
Yeah, I've talked to Amar and Susan about this a lot, and I'm very, very interested in trying this out. I admittedly haven't tried it out yet, hoping to make it to Chennai at some point to see this in action. But the results have all been very, very convincing and very impressive. I have not heard of the tuck-in before, and it's very intriguing. I wonder, Susan, how much cell damage might occur from pushing the transplant underneath.
Can I take that question now, or?
I think we have the video. Let's go ahead and see.
Yeah.
Video.
Do you have the video?
Go ahead.
Yes.
Please
yes,
go ahead. Yeah.
Yes, please go ahead. Please start, Dr. Suhas. The video is already running.
I'm not able to go.
You have to click out of your Zoom onto the video again. Onto the video again.
The videos.
We can see your video just started from the beginning.
Slides are seen. Namrata.
Yeah.
Slides are seen.
Yeah.
Yes.
No, it's a video on VLC, so you can just take the cursor back to the beginning in case you want to restart it. Not from there, but at the bottom you will have the VLC small, the cursor which runs the screen. You can just take it to the beginning. You can play it all.
Can you see that?
Not yet.
I can see your face nicely.
Suhas, you have stopped sharing again. Please understand. Play the video. Play the video. Play the video and then start share screen. It was coming nicely. Benny, you were saying something.
First, I'm taking your team access.
Are you able to see that?
No.
No.
Sir, please accept the request.
Suhas, just listen to what Jaswinder is saying.
It's come.
Yeah.
Yes.
Played. Yes. Yes.
Just play.
Don't do anything else after you played, sir.
Just leave it like that, sir.
Nicely visible. Go ahead and you can start talking now.
Not able to hear your voice.
Yeah, but is the screen seen?
Yes.
Okay. Okay. Now there's a light at the end of the tunnel. Now this is a story, a 20-year-old story, when a young man came to get rid of his glasses, and his refraction was -4 cylinder, and his vision was 6.6. The plan of action at that time was arcuate keratotomy. And status post keratotomy, his vision was -1.5 cylinders still left, but his vision was good. Patient wasn't happy. 3 months later, we planned a repeat AK with RK, and the post-op vision was +1 with -2.5. So now both of us were unhappy. And then patient was lost, and he came 10 years later when his cylinder had gone to 3.5. So that clearly means there was some amount of ectasia that was happening. 15 years later, he comes with a very poor vision. He undergoes surgery. By then, his cylinder has gone to -6. And 20 years later, he comes with a very bad vision, very bad cornea, and his vision is 2 meters. Now, just around this time, when I'm wondering what's happening, there's some good news and a ray of hope comes from Agrawal's of Chennai. And he talks about pinhole pupilloplasty. And the early results which he showed were quite encouraging, especially in very bad corneas where the vision that came out was extremely good. And the concept that he explained with style Crawford effect and the pinhole giving you depth of focus. And another thing that he explained was the importance of angle kappa and the decrease in chord mu to bring visual axis and pupillary axis closer. That seems quite interesting, where by doing pupilloplasty, you actually could, by bringing the pupil to the center, the chord mu could be decreased. So that led us to the strategy that I was really wondering how to go about it. I tried to constrict the pupil as much as I can, and using the two-hand technique, I tried to get the pupilloplasty, which was quite effortless. By using 4th row single pass, I managed to get 2 sutures. By then, I was all the time observing the visual axis. And at some stage, I felt that I still needed to get this in the center. So I used a cutter to make this pupil slightly distorted enough to get the visual axis in the center, with the hope that I would have it well centered. And I could have taken one more suture, but I was happy with it. The pupil was pinhole, and the results were quite elating. For the patient, it was like a rebirth, 612 with -4 cylinder. Even I was very happy. So that means there's always a light at the end of the tunnel. And I was very happy, and I would like to thank Amar for all the time coming back with newer and newer concepts. Thank you so much.
Thanks, Dr. Haldipurkar. I'll just remind everybody to please vote. The voting panel is working well again. And please don't miss out on voting. And I wanted to update Dr. Amar that, when we started out, we were in all on Facebook, YouTube, and through our web portal, almost 5,000 viewers and growing. And right now we have crossed about 7,000, and I expect that by the time we finish, we would have touched 10,000, and that would be a record. So, thanks to the most amazing show that you've been able to put across, we've never had these many viewers. The last time we did it, it was 8,000. And this time we are going to touch almost 10,000 viewers. And then we have several questions. I think I'll ask Namrata to ask the first one.
So the first one is for Dr. Mahipal Sachdev, sir. What about pinhole pupilloplasty? What is your take on that?
Well, I think what Suhas said and what Amar have been saying is that these are for desperate cases, and the basic concept is that you're making the pupil small and you have depth of focus. And obviously, these patients are pretty happy on these particular things. There are obviously questions that come up about the restriction in the field of vision if the pupil goes down to 1.5 millimeters or something like that, as also watching the periphery of the retina. But then these are desperate cases, and these cases without a graft, etc., will never have a depth of vision or a depth of focus once without a graft. And even if they do a graft, they may not come to the same. So I think for desperate cases, this could be an option that could be tried. And when, if required, the patient has some retinal detachment or something like that, you can actually, it's reversible, that you can actually cut the sutures and remove the suture and then go ahead and do those things. But I think everyone has his own options, the way one wants to do that. There are pinhole IOLs also that came in. So this is the concept, is to actually make the pupil small and get away with good vision without doing more aggressive or more invasive surgeries.
I have a question, Namrata, and this one is from Dr. Bhushan. And I'll ask Ron Kruger if he's, can't see him. The question is, Did you ever encounter iris cheese wiring while doing a single pass pupilloplasty? And which kind of iris should we avoid doing a single pass pupilloplasty? Is Ron here?
Yeah.
Yeah.
I'm on. I'm part of the Mickey Mouse panel here.
Such a pleasure to see you, Ron.
Yeah, it's good to see you.
So,
I think the thing is, you really want to make sure your iris is a normal, healthy iris. If you have an iris that's more atonic, a poor supply, you're going to end up having more of a cheese wiring. At least that's what I could say for iris pupilloplasty.
Can I make a comment, Gaurav?
Yes, please, go ahead.
To avoid the cheese wiring, what I do is, with the same 9-0 needle, I take the first bite as well as the other iris bite also. Instead of putting a 26 gauge needle, if you put a 26 gauge needle, it makes a bigger hole on the iris. So what I do is I make a hole in the, or take a bite in the proximal iris as well as in the distal iris with the same 9-0 needle itself. So that will reduce the amount of cheese wiring.
Partha, would you like to add any tips over here quickly? Yeah.
So yes, so cheese wiring is very important, and that actually frays and deters the pupilloplasty that has to be achieved. So I think Mohan said the right thing, that the smaller the holes in the iris created by the needle, the better it is. So that is definitely the way to go.
I would like to add one point to this. You should try avoiding the atrophic patches, and also from where the iris tissue is friable. You should try avoiding those areas and try to reconstruct it around those areas. That's one very practical point.
Dr. Namrata, there was a question for your presentation. Were you placing, this is by Dr. Lalit Mohan, were you placing pieces of limbal graft over cornea under the amniotic membrane?
You can do it either way, either over the amniotic membrane or under the amniotic membrane. If it's a child, then I would do under, because I don't want those pieces to be lost. And if it is an adult, then I do over it. But it doesn't matter as far as the results are concerned.
And if you have any questions on Susan's presentation.
There is a question for Professor Jagat Ram, sir. There is a question for you. Did you put a lens there? So was that lens customized? Where was it, obtained from?
Yeah, this was a customized lens, and it was by the care group of people. And I can say now we have 8-year follow-up of the patient. This child, now a child is grown up, visual axis is clear, rather that it is much more widened and clear. Initially, refractive error about 8 years back was on the plus side, plus 1.5 diopter, or now it is toward the minus side, it is minus 1.75 diopter or so. So this is I think follow-up. We are continuously having follow-up of this child and also photograph.
Okay, thank you, sir.
Thank you very much, Namrata and Gaurav. I think I'll ask some final comments from Ron Kruger for this session, and then we'll move on to the next one where Mahipal is going to take on his team. So Ron Kruger, can you tell us any final comments?
Well, for the last session with Mitch Weikert's team, I thought it was really very good in terms of cornea and iris, an area that's important. I especially like the limbal transplant talk, as well as the air-assisted PDEC talks, and the pupilloplasty talks were very supportive as well. And I think there's a lot of real pearls that we can glean from that.
Thank you, Ron.
Thank you very much, Ron. And now we ask Mahipal, we are having the last team, which is the devices team. And we have the president of the All India Ophthalmic Society, who's also the chairman scientific committee of IIRSI, to be the captain of this team. Mahipal, game is on.
Yeah, thank you very much, Amar. And I think, as the other captains have said, that the number of people logging on is increasing, because they have all waited till the last team came, because the first 3 teams are just going to not talk anything good. So that's why, Gaurav, the numbers are increasing. You should know the mystery behind it. So we are the devices team, and we are going to be the finishers. It is the typical T20 overs match, and the last few overs, we are going to blast sixes all over the field. So let's start with the devices team. And with the devices team, we have Dr. Priya Narang from Ahmedabad, who is going to talk about a new autoperimeter. And then we have Dr. John Hart from Michigan, and he's going to talk about PCR in a silicon-filled eye with in a silicon IEA tip. And then we have Dr. Kevin Miller from UCLA, Los Angeles, and he'll be talking about the various segments and rings for subluxated cataracts. And I will bring up the last batsman in this entire OPL, and I'll be talking about the chandelier's illumination for corneal opasties, where even though we have bad corneas, we are still able to do good phacoemulsification. So without much ado, let's start with Dr. Priya Narang from Ahmedabad. Let her talk about her new autoperimeter. Priya, over to you.
So hello everybody. I start sharing my screen here. At the outset, I would like to thank the AIOS and the IIRSI for giving me this wonderful opportunity. We are the devices team. And we present here Advanced Vision Analyzer, which is a mobile virtual automated perimeter. Standard automated perimeters have been the preferred option for the visual field testing for the past 30 years. However, these devices are bulky, they need a specialized darkroom, restrict patient posture, and are difficult to execute in patients with special needs. Also, the high cost of computerized field analyzers drives the cost of field examinations, thereby limiting the reach of visual field examinations, resulting in vast prevalence of undiagnosed glaucoma. In order to overcome these challenges, our mobile automated perimeter is proposed. Our comprises of a head-mounted device, similar to a virtual reality headset, a patient response button, which is a handheld device, and an Android tablet that serves as a controller to perform, record, and analyze the test program. The head-mounted device is lightweight, and it allows a high degree of flexibility in patient position. The HMD is battery-operated, has an adjustable headband, and records the patient's response after presentation of the stimulus. During the test, the system obviates the need to occlude the fellow eye. The PR button is connected to the HMD through a wire, and for a given stimulus to be recorded as seen, the patient presses the button. The computing system then determines the test results with the record information. The test control device is a tablet that is connected wirelessly to the HMD, to the patient response button, and to the cloud server. The device is portable. It does not need a darkroom to perform the test, and also can be performed in supine position. To set up a test, the administrator initially logs in and pairs it with a headset, followed by input of details. The tablet has HMD details, settings, new tests, and reports. AVA offers white-on-white perimetry with a stimulus intensity that ranges from 0 to 40 decibels, and the test is performed with Goldman 3 stimulus size. The test details can be set by choosing the eye that needs to be tested, followed by the test pattern that is either a 24-2 or a 30-2 program, or a test strategy that can be either a screening, a full threshold, an ELISA test, or an ELISA fast. Other details that are fed into the system include personal details, such as patient's name, age, sex, that helps to retrieve the stored data, which is stored on the backend server. The clinical data on AVA is encrypted and is therefore secure. The eye tracking system tracks the pupil movement while the test is being conducted. Hence, it helps to check for fixation losses. The interpupillary distance can be adjusted. Refractive errors can be corrected in the AVA system. The device can be connected wirelessly to the printer, and the reports can be delivered by email. The printed test report consists of patient information, reliability indices that comprises of fixation losses, false positive, false negative. It contains absolute threshold values, grayscale pattern, gradient plot that is based on threshold results obtained. The results include defect significance and global indices that are compared with the normative database built specifically for AVA. These are the various kinds of visual field defects detected in grayscale pattern. Comparative studies between AVA and conventional automated perimeter demonstrates equivalent ability to detect all forms of visual field defects. The report generated by the device meets the international standards and adheres to the format that the ophthalmologists are accustomed to. To summarize, the device is portable. It does not have any learning curve, accurate detection of visual field defects. It's almost 1/5 the cost of a standard perimeter, allows postural freedom for patients. It offers screening and threshold both. It's helpful in rural areas, and it's also useful in post-corona pandemic situation where it allows performing the test with adequate social distancing. And this is what we actually look forward to future. AVA allows the need to meet the global demand for quality eye care in the era of digital health. And I am glad to be a part of AVA family, and we are the future of ophthalmology. Thank you so much.
Thank you very much, Dr. Priya Narang. You are always innovative and you always bring in new techniques. And I think this is going to be a game changer for autoperimetry. So without much ado, let's go on to Dr. John Hart, and he'll be talking about PCR induced with a silicone IA tip. Dr. Hart, please.
Amar, thanks for inviting me to present. Here in Michigan, we're still under COVID-19 lockdown. So outside of emergencies, we're not seeing patients. My newly found free time allows me to take advantage of the great outdoors in spring turkey hunting season. If you listen closely, you can hear them in the woods behind me. That's why I'm in full camouflage with my turkey decoy, Henrietta.
Nice.
For this presentation, I will not be targeting my feathered friends. Instead, I aim to uncover an occult cause of posterior capsular rupture caused by silicone INA tips. Enjoy.
Posterior capsular rupture, or PCR, caused by burrs on metallic INA tips, was first described in 1985. Silicone INA tips were released by Alcon in 2002 as a solution to this problem. Since adopting these tips, PCR due to INA was nearly eliminated in our institution. A recent rash of PCR cases caused by reusable silicone INA tips prompted us to investigate. I contacted Alcon, the manufacturer of the INA tips. They recommended investigating how the tips were cared for. To my dismay, our surgical center deviated from the manufacturer's recommendations. Was this the cause of our problem? The staff of the surgical center was retrained to properly care for the tips. Then new silicone INA tips were returned to the operating room. I was hypervigilant when I resumed use of these tips. The first tip I employed had been used 5 times. Under the operating microscope and noted no abnormality. During capsular polishing, a PCR developed but was momentarily obscured by the INA tip. The development of this capsular tear is best viewed in slow motion. The day prior, my partner had a similar episode. In his case, the PCR occurred when the aspiration port was turned up away from the posterior capsule. Despite proper care, we were still getting PCRs when using these new tips. The tips from these cases were saved for examination. The tip that caused a PCR during capsular polishing showed a normal, intact silicone sleeve, but the distance between the aspiration port and the underlying metal tube was only 100 microns. When the silicone sleeve was removed, the opening in the metal tube closest to the aspiration port showed a sharp burr. The PCR caused by this tip likely involved aspiration of the posterior capsule through the aspiration port where it came into contact with the burr on the inner metal tube. The tip that caused a PCR when the aspiration port was turned up revealed a tiny defect in the silicone sleeve opposite the aspiration port. Scanning electron microscopy shows a 50 micron tear in the silicone sleeve. Removal of the silicone sleeve revealed large burrs in the end of the metal tube beneath the tear in the silicone sleeve. This PCR was caused by aspirating the posterior capsule through the tear in the silicone sleeve where it encountered the sharp burr in the underlying metal tube. Tips rejected due to visible damage prior to 10 uses typically showed large tears in the silicone sleeves. Beneath these tears were equally impressive burrs in the opening of the metal tubes. Last, we examined a new and unused tip. Although no defect is apparent, a divot in the silicone sleeve can be seen just above the end of the inner metal tube. When the silicone sleeve was removed, Significant burring in the opening of the metal tube is apparent. Sharp burrs in the end of the inner metal tube are the source of PCRs with this instrument. Contact between the posterior capsule and the burr can occur during aspiration, either through the aspiration port or through a tear.
I think the video stopped, I think, in between.
Yeah.
Dr.
Video and
John,
audio.
are you there?
I think we've lost connection because both the audio and the video feed is gone. I think we'll have to just wait for a few seconds till he comes back.
Maybe you could ask a question.
Move to the next one.
Meanwhile,
We cannot move till he exits his screen, actually. So we can have a question. I have a question.
There is a question which says that what about pinhole pupilloplasty in those patients who are on URMX or who have a floppy iris? Is there any, are there any different problems with that?
Actually, I have patients with iris prolapse or something like that, it helps a lot, because when these floppy irises are there, suppose at the end of it, when it's flopping a lot, it's not good. So I always do a pupilloplasty and make things much better. So actually, when you have these iris prolapses keep on coming, sometimes you see them. Yeah, he's come back on screen.
Amar, I'm back. I apologize.
Okay, yeah.
A little technical difficulty there.
Continue, John, please.
Oh no, that was it. I didn't know if there were any
can you
questions.
just stop sharing the screen?
Yeah.
Just stop sharing.
So I think the person at the back end can do that too. Like the admin can switch off his screen for him because it may be stuck. Can we have Gaurav, who is at the back end team, please switch
I
off?
already did it, but his internet stuck.
So how do you get out of it?
Am I?
John, can you just switch it off the share screen? Stop share.
It won't let you. I cannot start share screen while the other participant.
Maybe if he exits the Zoom meeting and rejoins, by that time I think.
Just press leave meeting.
You can leave the meeting.
Leave the meeting and join back.
Leave the meeting, come back again.
Or switch off the computer totally.
Yeah.
Dr. Mahipal, you don't do that to your team members, do you?
It's Gaurav who is the admin, so you are placing the bugs in there, right?
Dr. Benny,
John,
if I can answer in that in the meantime about the question about the use of air.
John, can you just switch off your computer, John?
Yes.
Switch it off.
And he also has to leave the meeting, then only it will come up.
Yeah, if you leave the meeting and come back, it will work.
Come back.
John, press leave meeting.
So Susan, can you answer that question, please?
Yeah. So basically, Benny, we've been doing this technique now since many years, since about 4 to 5 years now, or around the time that we started PDEC, we realized that we have to do this technique as well to be able to really harness all the advantages of that PDEC graft. You know that the PDEC graft is much more resilient and stronger. You can just drag it along like a DZEC. So we got all these advantages, and we found that using this technique helped us get the best results of both DZEC and DMEC together. And we've not really found our results as far as the endothelial cell counts are concerned to be different from that of DMEC. They very much parallel it, and we also published this in a couple of papers. And also, I also feel that just simply because we are able to float up the graft so much earlier than with the DMEC, I think our cell count is actually protected in a way, you know, just because of that, because we don't have to manipulate too much. We're not too much bothered about concentration. We try to unroll it as far as possible, which is almost up to the edge, but we are not too much bothered about the peripheral edge folds. So those peripheral edge folds can still be left behind and taken care of later.
Thank you. So Mahipal, can you continue, Mahipal, your team members next?
Yeah, Kevin, it's all over to you with your magic hand, your magic fingers and the devices. How do you handle subluxated cataracts? Over to Kevin.
All right. Well, first off, Amar, thank you for involving me. Thanks for the invitation. The AIOS is always doing good things, and the IIRSI, I appreciate it being in India, just in January for the meeting in Rupture. It seems like it's a billion years ago. The AIOS hat is to remind everybody to come to the virtual meeting the 16th and 17th. And the I up here is I'm watching how you're voting, so make sure you vote for the fourth team. Welcome to Southern California, where we have palm trees and we have beautiful ocean. Finally, the sun has come up. I got up in pitch black to come here to my office to do this presentation. So welcome to Southern California. And here's my presentation. So, subluxated cataracts. This is a post-traumatic cataract. You can see how the lens is tilted. So you have to plan these things out. We've obviously got zonular loss going on over on this side of the lens. So you want to create your Hoffman pocket before you enter the eye. So we're going to do that. You want to do your vitrectomy. You got to get all that vitreous gel out of the front of the eyes. It's just going to wrap around all your instruments. So I like to go in through the pars plana and get that portion of the gel out first. Obviously, this eddio is vitted down, so it's not, you're not going to see the whole thing. But it's important to go after the posterior vitreous first. Try to preserve as many zonules as you can. There's obviously significant loss. After the vitreous that's posterior is gone, now we're going to take out the vitreous in the anterior chamber, being very careful not to let the iris jump into the vitrector, because irises like to do that. Now at this point, we've done the capsulorhexis, so now we need to secure the lens so that we can then phaco it. So we're using an MST retractor. This is a capsule retractor. And we had pretty decent zonular support elsewhere. You notice this patient is sleeping, and so every time they breathe, the head suddenly moves. There he goes, breathing again. So we're going to take out the cataract in the most gentle way we can. Here I'm doing a divide and conquer technique, but I don't think it matters. You could do a chop if you want. So the cataract is out. This patient had a lot of capsular fibrosis, but that's okay. We can take care of that later. The next device to use is a capsule tension ring. I like to put them in with inserter devices, but you can use forceps if you like. Now comes the capsule tension segment. I've already passed the suture through the Hoffman pocket beneath the iris and out through the incision. We feed it through the capsule tension segment, snake it back into the eye and out to the Hoffman pocket. It's important that the loop part of it goes in the bag, and then this eyelid part has to come up over top of the capsulorhexis. We're just going to assure that. And I don't think it's critical that you anchor the sutures or tie them down right at this point. I think you can save that until later. I think it's really important in these cases that you really polish the anterior capsule well. I do this in 100% of my cases, but it's especially important and especially useful in these cases where later on the capsule is just going to contract down and might put stress on the remaining zonules. By polishing the capsule, we can make sure that doesn't happen. Now, just whatever lens you like to put in here, it's a single piece acrylic lens. Once it's deployed and inside the bag, then we'll go back now and retrieve our 9-O-proline sutures, and then we'll anchor down the capsule tension segment, making sure that the lens is nicely positioned in the center of the eye as we do so. And because of the beauty of these Hoffman pockets, those suture ends will just disappear once they're trimmed. So there's no need to suture the Hoffman pocket closed. In fact, no need to suture anything that's going to have to be removed. Lastly, we go in with the IA probe. We take out the cortex of viscoelastic. Lens is perfectly centered, and the pupil wasn't so messed up that we needed to suture it. So that's the case.
Thank you. Thank you very much, Kevin. And now we go on for the final presentation, and I'll be talking about the use of the chandelier's illumination for doing phacoemulsification. So enjoy this video. So when you have problems of corneal opacity and phacoemulsification is required through, say, corneal opacity, nebular, macular, or some amount of bullous keratopathy, you can use the light from a chandelier's fiber because it goes to the retina and comes back and retro-illuminates the lens. The importance is that it is self-retaining, it's a self-sealing wound, and it provides excellent visualization even through hazy cornea, and the design is good. So let's enjoy this. If you have to play in darkness, that's what we say, if you have to play in darkness, under those circumstances, you need an illumination from the proper area, and you can hit your goal. You can do the golf, or you can play basketball, or you can do the frisbee, whatever you want. The only thing is you need a proper visualization. So let's see in a 78-year-old male with a dense corneal opacity, absolute eye, the other eye, and a 660 vision, and you need to do a phacoemulsification. So you go in on the pars plana, put in the chandeliers after you have put the trocars. You see it's self-illuminating, self-retaining, and you saw the image. This is with the microscope on, and we have put in trypan blue, and just to see the quality of the image as if there is no corneal opacity that is remaining. If you switch off the microscope light and just put on the chandelier's endo illuminator, and you see, you can see a perfect capsulorhexis. You can see the difference again as it comes out. And let's see the depth perception. It is better than the normal phaco through a microscope, because you can see that the depth perception is excellent. And you can see the phacoemulsification going on pretty well in this particular case. So you can see once we put in the viscoelastic, then we will use this for the IA, and then again for putting in the intraocular lens. So you can see that there is absolutely the bypassing of the scatter of the microscope light, because you are putting the light from the behind, and this is a perfect example of doing phacoemulsification despite corneal opacity and what we call phaco in darkness. So friends, let us move ourselves to other cases. It is something that we are doing absolutely routinely, where we are not doing a corneal graft. If we can do a corneal graft, there is no issue on that. But if you have to do a phacoemulsification in these cases, see again, dense central corneal opacity, poor vision with cataract, and this patient wants visual rehabilitation. Again, you make a side force, put in trypan blue, look at the play of the corneal opacities, and look at the chandelier's endo illuminator working for you. The microscope is off, and you can see again, look, can you see the ease with which one can do the phacoemulsification, and you can easily see the depth up to which you are going in these particular cases. And if you have to actually do it for the beginning to the end, the irrigation aspiration, the IOL implantation, it will go always in the bag, because the quality of the vision that you get along with the depth perception is very, very good, and that's the end of the surgery. Let's go on to our final case, sisal bulbi, one eye, dense central corneal opacity. Again, just measuring the site for incision, for getting in. You can see it's 25 gauge, it is self-retaining, and you just put the endo illuminator. We have again used trypan blue dye, and again you can see microscope off, chandeliers on, and let's see again a fantastic capsulorhexis. There is, as if there is the corneal opacity is not there, it never existed, but it is there, and you are bypassing the light going from the top. The light is coming straight to the retina and coming back, and this is something that you can enjoy doing the surgery. Mind you, it's all of us have this chandeliers endo illuminator light source with our vitrectomy machines, and you have your VR colleagues with you, and just help them, just ask them to help you in these particular type of difficult cases, and you will be able to get through them with great ease and with no effort whatsoever. So friends, that's the end of the presentation from the devices team, and hope you have enjoyed the presentations that the devices team has made, and we look forward to your vote and your support for the best team. Thank you very much.
Thank you, Dr. Mahipal. I have a question for Priya. Priya is there. Priya,
yes.
This is from Dr. Harsh Kumar. He wants to know, is there any data on your visual field analyzer where you've seen, how the visual fields progress?
Yeah, that's a very good question from Dr. Harsh. I think he's a glaucoma specialist out there. The progression data analysis, yes, we all in our team, we are working upon it, and I think we should be there. It should be there in the device within the next 3 to 4 months, because it's a new device that we have launched. So now progression data is something that comes up over a period of time, and we are definitely going to incorporate it into the device. Maybe just give us 3 or 4 months extra. I think we should
even for the cost you are working on it.
Yes.
We'll have the questions right after this poll because the backend team has to take the answers from the poll and put them together. I'll quickly run the poll for the best headgear for the teams and for the panelists. After that, we'll have the question answer session and lots of questions coming in from the audience to Namrata and me. I'll quickly share my screen. So for the audience and backend team, please be ready to vote on your panels. We have votes for the best team for the headdress. So there will be 4 teams, as you can see here. I'm sharing my screen. So now going on the first, we are going with the panelists first. So for all our panelists with all the amazing headgear, we have, you will have on your panel one possibility to vote for one of them. So it's Ron Kruger, Benny Jeng, Dr. Lalit Verma, Dr. Ron Yo with the headgears, Dr. Partha Biswas, and Dr. William Fishkind. So you have the poll on your panels, and you can go ahead and vote for your favorite headdress for the panelists. And you will have 1 minute to vote. And after that, I will take you to the teams. So please vote quickly, and as soon as your votes are through. So going on to now the best headgear for the teams. We will have a team award for the best headgear. So you'll be voting for the teams, all right? So this is PC Rupture team. This is team number 1, in which there's Dr. Rohit Omprakash, there is myself, there is Dr. Ashwin, and there is Professor Jagatram. So if you want to vote for this best headgear team, you can vote for this team. If you want now going on to the next team, and I hope I'm keeping pace with the backend, please be careful that we don't want to spend more than 15-20 seconds on each. So I'll request the audience to quickly vote, and we'll go on to the next team now. Team number 2 is the IOL team. So we have Dr. Eric Donenfeld, Dr. Brian Kim, Dr. Mohan Rajan, and we have Dr. Dean Oano. So with the natural headgear there. And so this is the IOL team, and I'll request the audience to please vote for them. And see if you like this team, you can vote for this team. And going on now to team number 3. This is Dr. Namrata Sharma, Dr. Mitchell Patrick, Dr. Suhas Haldipurkar, and Dr. Susan Jacob. So if you think that this team has the best dress, you could vote for them.
So
and,
I would Gaurav, just like to bring to your attention that Dr. Mitch has done a very good backdrop for us on Corona Crushers.
Yes, I saw that.
Although it doesn't feature here, but all of us are behind that Corona Crusher.
For a moment I thought it was cornea crushers, and then I realized it's Corona.
Corona Crushers.
I'm joking. But it's amazing. Fantastic job. And then we have the team 4. And if we want to vote for team 4, which is the devices team, and if you would like to vote for the devices team, we have Professor Maipal Sachdev, and we have Dr. John Hart with amazing headgear, Dr. Kevin Miller, and Dr. Priya Narang. So this is team number 4. And if you thought that this team did the best job with the headgear, you can vote for them. So this completes our poll. If you are still not voted, quickly please complete your vote for the best team headgear, and that way we will be able to go on.
Dr. Mahipal has the most original headgear.
Yeah.
Yes, absolutely. No doubt about it. No doubt.
I think by the time everybody comes out of Corona, everyone is growing their beard. So I have decided to distribute turbans free of cost in India.
That's a good one. Well, I think it's very good.
Done with the poll for the teams, and while the poll is kind of populated and it's sent to me, Dr. Amar will take over. Dr. Namrata will ask a few questions. We are setting up the answers, and Dr. Amar has to do the poll for the judges' choice for the best video and for the best team as well. But Namrata, you can take questions first.
There was one question which is for Dr. Lalit Verma. Since he's a retina surgeon, everything from the retina, we've taken into cornea, whether it's endo-illuminator for phaco or C3F8 or air for the tamponade that you use, or intravitreal scissors or micro scissors or micro forceps. How do you feel about it? I mean, have you been able to do the other way around?
You see, I am a retina guy, but I sat all across 2.5 to 3 hours just seeing that all the instruments which we have innovated, and you people can't do your surgeries or can't exist without that. So it's a happy feeling for me. Even there were not much retina videos, But you see Maipal presenting chandelier, and Namrata and Susan Jacob taking the use of air pump. Without that, all these PDEX will fail. Believe me. Happy to see this actually.
So that's, I think, because of Amar, because he was rather a retina person, and so we, you know.
But I must say, Namrata, this is a wonderfully conducted OPL by you and Gaurav. But hats off to Amar, who has done it yet again. And you know, I thought virtual will be a fiasco, but I think he has proven that it is much, much better than even a physical OPL. And as I am being told that it's crossing 10,000, 3 cheers to the entire team of OPL.
Thank you very much, Lalit. Well, we'll ask now William Fishkind. Bill, can you tell us which is your opinion for the best team headgear? Can you vote? Tell me one name which you preferred the best. Bill?
I had to laugh at a few people, Dr. Hart being one of them. It wasn't so much what he was wearing on his head, but what he was using for his sound effects. I was waiting for a turkey to come jumping out and him bag it for a turkey dinner tonight. So I thought he was pretty good. And Mitch Weichert, it's hard to take anybody seriously with that hat. And Mitch is just so brilliant. I think the two of them, to my mind, were just the funniest of the hats.
What about Benny? Benny, what about you?
I loved the turkey. I have to say that was really a nice touch.
So you love John Hart the most.
I do love John Hart the most.
And let's ask Ron Yo.
Oh, I thought Mitch Weichert was really outstanding. Absolute winner by a streak.
Mitch, you're winning it quite comfortably, it looks like. Let's ask Ron Kruger. Ron Kruger, are you there? Or Partha?
Partha, you have to unmute.
You have to unmute, Dr. Partha.
John Hart. John Hart.
No doubt
okay. About it. And what about who's left there is Lalit? What about you?
Yeah, undoubtedly John Hart was the most amusing kind of headgear.
Oh, that's great. So I think it's going without saying that you're having John Hart and Mitch Weichert as the leading contenders for the best headgear there. Anyone else? Is Ron Kruger there? I think, Namrata, any more questions? And Gaurav, are you ready with the poll?
Yes, so I think I've just received.
Yeah.
Let me.
One second, Gaurav. Yes, Ron?
Amar, no, this is John Hart. I just wanted to thank you again for all this encouragement. The turkeys are going crazy here.
John, you won the poll from the judges.
Amazing.
Straight away, you know, and with Mitch, the second placed, I think. So let's hear it from Gaurav.
Entertainment takes a big role.
Share it with you right away.
Yeah.
Yes. So I have a call from the backend. Huh?
So he's going on live, ladies and gentlemen. All of you are seeing it going on live. Gaurav is getting it exactly from the IT team there. Who's won the best person, best team, everything like that. Namrata, while he's getting the answers, any questions?
So there's a question for the Yamani technique, which IOL can be used?
Brian?
Brian is there?
Well, I think you need to have a lens that has haptics made of polyvinylidene fluoride. In the US, it's the Zeiss CT Lucia lens. But then there are others internationally Dr. Yamani has used. I think there's 2 other brands. I think that with the modifications that I've done, which really reduce the manipulation of the haptics, you can theoretically do this with haptics made of PMMA as well. And I have, using the artificial eyes, done this with the MA60 AC lens, and I was able to successfully cannulate them. If you do the PMMA haptic lenses, you do have to use a 27 gauge needle. You can't use the 30 gauge thin wall needle if you do it that way. But I think as a novice surgeon learning it, a lens with polyvinylidene fluoride haptics is the way to go.
So Gaurav, are you ready?
There's another question for Priya. Priya, how do you compare AVA versus MRF field by iPad? I think not very many studies would have been done on this.
Absolutely. We have not yet compared that. We have just compared it with the standard automated perimeters that are into the market.
Okay.
Yeah.
Gaurav, are you ready?
Unmute Gaurav.
Gaurav?
Okay, I think it is there.
I think it's just, he's not got it yet.
Right now. Can you see this? So I've just received this from the backend. This is for the headgear best team.
No, Gaurav, slideshow is not on.
Is it?
No, it is not. It went off.
Sorry. I'll just do it again. Yes. I'm sorry. Is it visible now?
Yeah.
Yes.
Okay. So this is the report which they have sent. Okay. So this is for the headgear, for the team award for the headgear. This is in the order in which they were polled. So, so it came as 1, 2, 3, 4, which means they're exactly in the order in which the teams participated. So I think from this, what I can understand is that the winner is the PC Rupture team, and second, the runners-up is the IOL team, and then the cornea and iris team, and the last is the one with the natural headgear, I think.
Gaurav, are you sure this is the correct polling? Because it shows
Yes.
that's the order of the teams.
It just shows the same order.
I think I'll just request Jaswinder who should be online as well.
I think, listen, Gaurav, leave it, Gaurav. Because I think just showing the order.
Okay.
It's not showing it properly.
I can ask Jaswinder who's listening on
Because
to this. Jaswinder,
Gaurav, listen to me. Doesn't matter. I think John Hart wins it with Mitch Weikart.
Right. So
I think that should be enough then for us.
Kindly go to the next slide. Yeah.
Okay. Okay, this is for the best video. So for the best videos, for the team award, this is for team 1 and team 3. So team 1 and team 3. Best individual video award. First winner is Dr. Jagatram. The runners-up is Dr. Namrata, and the second runners-up is Dr. Mahipal Sachdev. This is for the best individual videos. So I think these are the 3 awards that we had. These are for the best individual videos. I'll go back to the best team award. So I think the winning team is the PC Rupture team, and the runners-up team is the cornea and iris team. So I think I'll exit, and I think Dr. Amar wanted to take the final.
I think basically I'd like to thank everyone here who has come, all of them, from William Fishkind, Benny Jeng, Ron Yo, Ron Kruger, and those excellent people on the speakers and all. I'd like to thank also all the delegates, but most important is Namrata and Gaurav and Jaswinder from J&J and the entire back-end office who have done such a great job. Ladies and gentlemen, we have a great endothelial keratoplasty webinar again on 30th, Thursday. So do join us for that. It'll be a great one. And we are looking forward to you having this continued more and more webinars through Gaurav and Namrata. Namrata, final words from you.
I think we are thankful to all the participants from all over the globe who made it happen at their various time frames. We are thankful to the AIOS leadership, Dr. Mahipal Sachdev, Dr. Lalit Verma, Dr. Partha Bishwas from the All India Ophthalmological Society who helped in the collaboration. And of course, IIRSI, Amar, Gaurav, who again coordinated the same. All the speakers from all over the globe, all the delegates and the people who are watching it, the sponsors, Johnson & Johnson, Mr. Jaswinder from the back team, and Gaurav, Mr. Gaurav from the person who was managing the audiovisual inputs, and also our people at the back end from the office, Dr. Rakhi and Kripal. So thank you, everybody. Thank you so much.
Namrata, I have also received for the last poll that we did. Quickly, I'll show you. Can you see this one? Which team has the best headgear? So this is for the team, and I also have the award for the best panelist. So in the panelists, the winner is Ron Kruger with 30% of the votes, and the runners-up is Benny Jeng with 20% of the votes. So these are the which panelist has the best headgear as per the audience poll, and which team has the best headgear. I think that's the vote. 28% for team 1, 20% for team 2, 26% for team 3, and 24% for team 4.
Thank you very much, Gaurav. But ladies and gentlemen, everyone here is a winner, and also the audience. You are the biggest winners, because to get so many numbers coming in for a webinar, the idea is basically one thing: we are going to defeat the coronavirus once again, and I'm sure we'll all meet again nicely in some conference or the other. Have
Dr.
a nice
Amar,
day and time.
would you like to announce about the
Can I
upcoming
just announce the court martial?
the one which
Yeah, please. Partha, go ahead.
Yes. So the next program that we have is the court martial Corona May Day calling, and that's on the 1st of May. India time is 4 p.m. and we would invite all of you to join in May Day calling international. Again, an international faculty is going to be there to fight Corona. How we have fought, how we are going to fight. Thank you very much.
One more that I would like to announce, and that is tomorrow from the international experts, Dr. Kinoshita from Japan, Dr. Jodhbir Mehta from Singapore, Dr. James Shudush from US, Dr. Vishal Janji from US, and from all over the European countries, because we wanted to see how international people are coming back to ophthalmic practice. So there'll be one tomorrow at 6:30 p.m. and all of you are invited. So.
And a final word from Dr. Mahipal, President of AIOS.
Well, thank you very much, Gaurav, Namrata, Amar, and the other organizers. It's indeed been a pleasure. I think AIOS is being able to get all the top guys from across the globe to participate. And I think we have been able to organize both administrative, financial, economic, as also scientific and academic webinars through the last couple of weeks. I think great job done by all the panelists and all the participants. Thank you very much on behalf of All India Ophthalmological Society for being part of this fantastic webinar. And we look forward to your continued help, presence in our future webinars. Thank you, and stay safe, stay healthy, and stay strong. And we will definitely come.
And keep watching.
Thank
you very much.
Keep watching.
Any words
Thank
of
you. Thank you.
words from our foreign guests?
Thanks, everybody.
Thanks. Thank you.
Thank you,
Thank
team.
you.
Thank you, Gaurav, Amar, Namrata,
Thank you very
Mahipal.
much.
Thanks a lot.
Everybody.